Perfect. Okay, good morning, everyone. For those who don't know me, my name's Courtney. I'm one of the postdoctorate fellows here at the National Centre for Antimicrobial Stewardship. I help organise and coordinate our Journal Club webinar series throughout the year. This month, for the month of September, we're very fortunate to have a topic on digital health in stewardship. I'd like to acknowledge the hard work of one of our PhD fellows, Ron Cheah, who worked very hard to coordinate this webinar series, but unfortunately is unwell and unable to host today. And also apologies from our director, Kaz Thursky, who is off having the time of her life in Europe, taking some well-deserved leave. She was very passionate and excited for us to be having this webinar on digital health, and with the time difference, unfortunately, was not able to attend today. I'd also like to acknowledge the grounds that I'm standing on today, the traditional owners of the land in which I'm meeting at the Doherty Institute, and the people of the Wurundjeri, and pay my respects to the elders past and present. We have a great lineup today. So first off, as you can see here, we have Bethany van Dort. She works with the Digital Health Human Factors Group at the University of Sydney. She has experience in applying qualitative methods to implement and evaluate digital health tools in hospitals. Bethany is currently completing a Doctor of Philosophy in the Faculty of Medicine and Health at the University of Sydney, and her research explores the implementation, acceptance, and use of digital tools for antimicrobial stewardship in hospitals. So welcome, Bethany, and I'll let you take it away.
Thank you. I'll just share my screen.
Looks good. Ready when you are.
Thank you. Thank you for the introduction, and good morning, everyone. So today I will be presenting some results from my PhD. I'll first go through the results of a systematic review we conducted, and then I'll tell you a tale about digital intervention implemented into hospitals. And following that, I will go through the results of a study exploring AMS work processes across these same two hospitals, and finish up with some conclusions that I've drawn from this work. So we wanted to understand and synthesize user perceptions of digital interventions used for antimicrobial prescribing and monitoring in hospitals. So to do this, we conducted a systematic review. We started off with 1,000 papers and screened them, and studies were eligible if they explored end user perceptions of digital interventions and used for antimicrobial prescribing and monitoring, and also if they were conducted in an inpatient hospital setting. From this screening, we ended up with 15 papers. And then from these papers, we extracted results relating to the user perceptions. And then we used the UTAP framework or model to guide a meta-synthesis of these perceptions. So this is the UTAP model. It stands for Unified Theory of Acceptance and Use of Technology. And there are these 4 domains on the left-hand side. And the first 3, performance expectancy, effort expectancy, and social influence, impact behavioral intention, which is essentially acceptance of the system. And then that ultimately impacts use of the system. And then you can see the 4th domain there, facilitating conditions, directly impacts the use of the system. So within these 4 domains, there are also subdomains, and we classified the user perceptions as either barriers or facilitators and coded them to the subdomains. So this is what the distribution ended up looking like. There were 113 user perceptions in total, and after categorizing them into the domains of the framework, these are the different proportions. So performance expectancy was the biggest category, followed by facilitating conditions. And then this is the breakdown of the perceptions in each of the subdomains. So the subdomains were actually really helpful in enabling us to classify the perceptions, as they had very clear definitions and examples. So Jane, one of my co-authors, and I independently coded the different user perceptions into these categories, and then we met to discuss it. and reach consensus on them. And then if we were still struggling to decide, we involved a third researcher, Mel Baisari. I know this sounds a bit abstract, so I'm going to go through some of the main barriers and facilitators within the categories now. So within the performance expectancy domain, there's this subdomain of perceived usefulness. And this is the degree to which using a system will enhance users' job performance. So facilitators in this category were that the system was a trusted and credible source of information and improved the performance of tasks. For example, a quote from one of the papers was, you can back it up the next day if the next team asks you why, then you say decision support system recommended. So in that way, you're covered. And then barriers related to perceived usefulness were if the information in the system was not useful for the setting or the patient's condition. For example, one paper had the following quote: "A lot of the guidelines that the system has are not applicable to emergency. We hardly know what we're dealing with and therefore often require the best possible guess." So, therefore it was not perceived as useful for that situation. And relative advantage was another subdomain in performance expectancy. And that was defined as the degree to which using a system is perceived as being better than the precursor. So some of the facilitators we found were when the new system increased efficiency or it improved workflow. A quote from one of the papers was, "I think the approval template's definitely a lot quicker and easier." And then another thought the system offered a better and complete overview of patient data and history. And the job fit construct in performance expectancy related to how the capabilities of the system enhance job performance. So for example, when the system helps users identify problems, one user said, "I have learned things that I didn't even realize, and I inquire and get an order changed, and I know that I never would have caught that before." And then in contrast, if users thought the system provided outdated information, it was a barrier to acceptance. For example, one of the papers said, "For the closely monitored ICU patients, first results such as microscopy and first bacterial growth are important. Reporting will continue to be fastest by telephone. Electronic reporting was considered useful for reviewing patients, but obviously brought no real change to the ICU clinicians." So these clinicians thought that the information via the system was outdated, and they still preferred to get that information directly via the telephone. And if you remember in the UTAT diagram, the facilitating conditions domain directly influenced the use of the system. So one of the subdomains in facilitating conditions is compatibility. And the majority of perceptions relating to this subdomain were barriers such as the digital intervention not being compatible with existing workflow or prescribing cultural autonomy. For example, one of the papers said, ICU consultants using an antibiotic approval system reported that ICU patients required frequent addition and deletion of antibiotics. Therefore, seeking approval for every antibiotic was impractical. So here the intervention was not compatible with their workflow. And then there is a facilitating conditions subdomain in the facilitating conditions domain, which is a bit confusing, but it includes objective factors in the environment that make using the system easy or difficult. So in this category, facilitators to system use were related to the promotion of the intervention. You have to know about it to use it, and also the provision of education and training. And the barriers were, of course, the inverse of these. So a lack of awareness of the intervention or a lack of proficient training. And then perceived behavioral control, another subdomain of facilitating conditions. These perceptions related to users' own skills or knowledge and constraints on their use of the system. So reported facilitators were increased frequency of use and understanding of the intervention's capabilities. And then reported barriers were a lack of familiarity or knowledge in using or understanding the intervention. So one of the papers reported that most of them did not notice that the system had links to the corresponding sections of the electronic version of the TGA. And then social influence was the third largest domain. It's the degree to which a user feels that it's important for others to believe that they use the intervention. So the subdomains in this category were subjective norm, social factors, and image. And there were less perceptions in 15 papers that related to social influence. I've reported them together here. So one of the facilitators was when the system was endorsed by peers and perceived experts. For example, a participant said, "If I knew that it was recommended by the pharmacist and by ID and Micro, then I'm more than happy to use it." And then accordingly, an example of a barrier was that junior doctors did not accept recommendations from the decision support system due to the influence of their senior colleagues. For example, in a Singapore tertiary hospital, they reported that the juniors would override the decision support system when their seniors decided on a different antimicrobial. And then with smartphone apps, a barrier to use was that doctors were concerned about looking unprofessional when using their phones in front of senior colleagues, other hospital staff, or patients. And that related to the image subdomain. And this was a small category, only one paper had user perceptions related to this image subdomain. So to summarize, for system acceptance, a large proportion of perceptions related to the perceived usefulness of the system, and key facilitators included systems being trusted and credible sources of information, improving task performance, and increasing efficiency. And then key barriers were when the system was not considered useful for a particular context or not supported by senior clinicians. And then system use was facilitated by the presence of organizational and technical infrastructure. Barriers to use included the system conflicting with workflow and prescriber autonomy, a lack of user training, or a general poor awareness of the system. So this review's been published, and there are a lot more details and examples in the paper if you want to take a look, and all the perceptions are in the supplementary material as well. So now I'm going to tell you a tale of two hospitals, and this is exploring implementation of an antimicrobial surveillance tool. So there once was an AMS team at a hospital in Sydney that received a report every morning detailing all the patients on antimicrobials. The report was useful, however, often the AMS team might not review the patients until the afternoon, by which time the patient's prescriptions may have changed or they may even be discharged. So the heroic Informatics team came to the rescue. They designed a solution to overcome the report's limitations based on advice, testing, and feedback from the AMS team. The solution was a dashboard of all the patients on antimicrobials. In this AMS dashboard, the team could view all the patients, see if their blood results were available. They could filter this list by department or by the type of antimicrobial. Most importantly, the data was updated continuously, so it was never out of date. And the Informatics team had essentially saved the day. This was so successful that it was introduced to another hospital in the same local health district. And I know what you're thinking. The next hospital was overjoyed with the solution. The staff were dancing in the streets. The Informatics team had saved the day. They were heroes. Unfortunately, no, this was not the ending they had hoped. So that brings us to my part in this story. I wanted to explore how the AMS teams at these two hospitals utilized the same AMS dashboard and identify factors that promoted acceptance in use or did not promote acceptance in use. So I conducted observations and interviews with the AMS teams at both hospitals. And these teams included an AMS pharmacist and infectious disease specialists and registrars. So there were 8 participants at one hospital and 7 participants interviewed at the second hospital. For those of you who are interested in models, my interview guide and analysis was based on the SEEPS model. It stands for Systems Engineering Initiative for Patient Safety, and it's a human factors model that was developed to help understand the structures and processes and outcomes in healthcare. and their relationships. So I focused on these work system elements here: technology, organization, people, tasks, and the environment. And I think it's been really beneficial when analyzing my data, but also with writing up the results, which I'm doing at the moment. So the observations revealed that, generally speaking, both AMS teams at each of the hospitals performed the same tasks, like post-prescription review, providing approvals, providing advice. For the multidisciplinary team meetings, members of the AMS teams would meet with other units to discuss their patients on antimicrobials. But there were big differences in the use of the dashboard for these tasks. So the red indicates which tasks the AMS dashboard was used for, and you can see that it was used a lot for a lot more tasks at Hospital A. And through the interviews with the AMS team, we found that overall participants at both hospitals found the dashboard easy to use. For example, a participant said it's quite intuitive, and another participant said whoever's put the AMS dashboard together, they've made most of the basic functions reasonably straightforward to understand and use. And at Hospital A, participants found the dashboard invaluable in reviewing patients. This links back to the performance expectancy domain I mentioned in the systematic review. And several participants also believe the dashboard positively impacted patient safety. So one participant said, it definitely has an impact on safety in that I can immediately identify, particularly on this front interface, check doses quickly and efficiently. And then at Hospital B, participants had a different opinion. Many did not see a need for the dashboard. For example, this consultant said, so much of the work that we do is either we get automated reports in the morning, or alternatively, we're working closely with the pharmacist who has already done some of the work filtering. And we also found that some participants at Hospital B were not aware of all the features of the dashboard. And there was also one participant who wasn't aware that the dashboard existed. So you can see how this links back to the facilitating conditions barriers I mentioned in the systematic review as well. We also found a difference in the AMS team's involvement in developing the dashboard. Most of the AMS team at Hospital A was involved in developing the tool. For example, this doctor said they were involved quite a lot, more in the thought process that went into it rather than the actual IT side of it. And no one in the current AMS team at Hospital B was involved in the dashboard's development. So there were people consulted previously, but at the time of my observations and interviews, no one in that current team was involved in development. And then further to this, I also observed at Hospital A consultants championing the use of the tool. So they would recommend it in meetings and on phone calls to other doctors, and I never observed this happening at Hospital B. And I think this links quite well back to that social influence domain I mentioned in the review as well. So just looking at these two tasks specifically, post-prescription review and multidisciplinary meetings. So the AMS team conducted these tasks, but there were some differences in the way they were performed at each site. So for post-prescription review, Hospital A focused on all the antimicrobials, and they really valued the dashboard for their review. So one participant said the dashboard allows for that paradigm shift from a program that focuses on restricted antimicrobials to focusing on all antimicrobials. At Hospital B, their daily reviews focused primarily on the restricted list of antimicrobials. And Hospital B also had a different ICU eMed system. So due to a lack of interoperability, they couldn't actually use the dashboard for their ICU patients. The systems wouldn't allow it. For the ward patients, they could use the dashboard, but Hospital B still did not use it as comprehensively as Hospital A. So they would copy the list directly from the dashboard into an Excel spreadsheet and then use Excel to filter the antimicrobials, as opposed to Hospital A that used the dashboard to do all the filtering they needed. And I also think it defeated the purpose a little bit of the dashboard, because once you copy the data from the dashboard into Excel, it's no longer live data. So it's from the point in time that they copied it. So if they review the patients a little later from that spreadsheet, things could change. Both AMS teams held multidisciplinary meetings with other departments to review antimicrobials, and both hospitals held meetings with ICU and hematology specifically, but Hospital A also had a lot more weekly meetings with various surgical departments, and only Hospital A used the AMS dashboard during their meetings to facilitate their review of antimicrobials with those teams. So they would project it on the screen during the meeting and then go through that team's list of patients, or they would share it on the screen on Zoom if it was a virtual meeting. So to summarize, the AMS teams at both hospitals performed similar tasks. However, the use of the dashboard varied considerably. The dashboard was utilized more at the hospital where more participants were involved in the tool's development. At the hospital where the tool was utilized less, participants reported they received the same information through different channels or did not require the dashboard for their role. And then the approach taken for post-prescription review was a fundamental difference between the hospitals. The dashboard use may have contributed to this difference, with participants at Hospital A seen to use the tool comprehensively for post-prescription review, and Hospital A staff reporting that the dashboard was a key enabler of post-prescription review. So to conclude, I think an understanding of workflows and user needs prior to implementation is likely to reveal whether a digital tool will in fact be useful and used. To ensure that digital interventions for antimicrobial prescribing are accepted and ultimately used, we recommend organizations ensure that systems are evaluated, that the benefits are visible to users, and then also that utility meets expectations. And I think improved system interoperability and championing the use of these digital tools can also increase utilization. Thank you. I'd like to thank my supervisors, Mel, Jonathan, and Angus, and also Jane, Tim, and Rita, who assisted with data collection and write-up of this work.
Excellent. Thanks, Bethany, for a wonderful presentation. We do have a bit of time for some questions before we move on to Sarah's presentation. So I'll put it out to everyone in the chat. So we have the Q&A functionality if anyone would like to ask a question, or otherwise if you raise your hand and I can give you the functionality to speak on Zoom. And in that, while we wait for anyone else to ask a question, I guess I have one for you, Bethany. So with Hospital B, I guess what next are things being done to, like with the information that you've got, what are you going to do to help optimize how they use the dashboard? Or are we abandoning ship and not using it at all?
Yeah, I mean, I think generally there's some things that we could do, like increasing awareness of it and the functionality that it can have so that they can really see if it can offer benefit to their antimicrobial stewardship processes. But like this was a small component of work from a bigger study. And in the bigger study, we looked at like AMS work processes broadly, not just this tool. And a lot of other factors are involved in making AMS effective at that hospital. For example, they reported in interviews that they wanted clinical decision support systems, and they were one of the only hospitals that said that from the 4 in my study. And I think it came from like only reviewing the restricted antimicrobials, so they felt there was no oversight of the unrestricted. They reported a lack of ward pharmacists, so because of that, there wasn't review on the wards of the unrestricted. They thought there was a general lack of awareness of AMS at their hospital, and because of that, the prescribers were not really aware of policies. And I think they thought the hospital saw AMS as an ID initiative as opposed to a hospital-wide initiative as well. So I think all those components play a role in whether they think live AMS is useful and used in that sense. And so I think there's a lot of other factors that need to be addressed there, as well as increasing awareness of that intervention.
Awesome. Thank you. We have a comment from Leslie saying that the findings would be applicable to general practice too. They vary as much as individual hospitals, and yes, we would agree to that. And I guess at NCAS, we have a grant with an MRFF Research Data Infrastructure grant where we're hoping to, we're trying to improve the quality of the data, but ideally we would love to then work towards visualizing that information as dashboards for hospitals, primary care and veterinary care. So like it's really interesting to hear about what you've researched there, because that's all that stuff is very much applicable for what we're doing across a One Health space as well. So thanks, Leslie. There's no other comments. So we'll have time for questions at the end if anyone thinks of anything. But thanks so much, Bethany. Really appreciate you presenting today.
Thanks.
Yes. And then I'd also like to introduce Sarah. So Sarah, if you're able to show us. Yeah, thanks, Sarah. So Sarah Tang's an infectious disease specialist pharmacist at Singapore General Hospital. Her focus is in the area of antimicrobial stewardship, with a particular interest in innovation and translational research. And more recently, she's been exploring ways to leverage AI machine learning to improve the quality of antibiotic use. Thanks for joining us, Sarah. Do you want to just practice sharing your screen just so we can make sure that works? And then we'll get started. Yep. Perfect. We are ready when you are, Sarah.
Great. Good morning, everyone. Thank you so much for this opportunity. Hello from Singapore, where we're all in the same antimicrobial stewardship space. So for this morning, I'll just be sharing some of the work I've been doing around the use of machine learning. This is really an extension of what we've been doing using the standard prospective audit feedback guidelines, the core strategies of stewardship, and we found that we have a lot of trouble with the review of antibiotic indication for pneumonia specifically. So we have a lot of patients coming through our hospital, even in the whole of Singapore, with signs and symptoms that are suggestive of a bacterial lower respiratory tract infection. And we know that not all lower respiratory tract infections are bacterial and might not need antibiotics. But to be able to make that decision, other than having to deal with a very busy hospital floor, a doctor would have to typically go through a vast amount of information on the medical record system, ranging from what are the symptom complaints to what the lab tests, looking back in history, whether the patient had what sort of past medical history, or the radiology reports. To be able to make that decision. And this is not easy because the data is usually very complex for our hospital, which is at about 2,000 beds. And we do see patients also from the hematology, oncology, solid organ transplant, BMT. We are dealing with quite complex patients with very complicated history. And we know that there really isn't quite that one gold standard to be able to help us distinguish whether it is bacterial or not bacterial. And sometimes maybe they don't even having a respiratory tract infection per se, but perhaps something that mimics like it, like congestive heart failure or exacerbation of asthma. So we find that there's a lot of human variability in this decision-making process, and really to make that diagnosis right on the spot of whether the patient requires antibiotics and whether the patient does have a bacterial pneumonia, it's very challenging. So in our hospital, we see quite extensive antibiotic use. That's about 1 in every 2 inpatients on any day from our point prevalence study. And if we were to look at those that were started specifically for suspected pneumonia, in fact, about 30% actually do not have an infection, and this might mean that antibiotics could have been avoided for these group of patients. So we have our hospital stewardship team that does the review, and we found that if a intervention is being made for these patients, we're generally able to save about 2.6 days of antibiotic use. But stewardship, it's heavily manpower dependent, and also depends also on the training of the team. And so we wanted to explore if we could have something as a guide to help clinicians make the decision on whether antibiotics should be initiated at all, right at the point of prescribing, rather than await for the prescription to already have been made, patient will have received it, and then have the stewardship team come in to try to change what has already been started. So what we did was we put together inpatient encounters across 2 years. We looked at cases that had ICD-10 codes of interest. So we looked at both infectious causes as well as non-infectious mimicking conditions. So for those non-infectious or clearly non-bacterial causes, we would put them in the group as the ground truth no group. If they had an ICD-10 code that could suggest a bacterial lower respiratory tract infection, we next looked at whether they had antibiotics being prescribed. We have an assumption here, which is usually that if there is no antibiotics prescribed, it's quite clearly that there is no bacterial infection involved. For those that did have antibiotics used, we actually had the stewardship team come in to review these cases. The reason for this was because of the situation of overprescribing. So we saw just earlier that 30% of them actually do not need antibiotics. So we wanted to reduce the amount of noise that was coming from this group of patients that did not really have bacterial pneumonia. So only when the stewardship team has verified that the indication for the antibiotics was valid, then only this group of patients entered into our ground truth yes group. So all in all, over the 2 years, we had about 2,900 patients with a ground truth yes. We had a lot more though in the ground truth no group, but for the purpose of the modeling, we decided to do a random sampling of an equal number of patients from the ground truth no, just for the purpose of our model building and testing. So the next step we did was, after identifying the patients of interest, we went to eHINTS, which is our institutional data warehouse. We collected information, or rather we extracted information in these subject areas. So other than demographics, we also pulled their medical history, the nursing activity, for example, did they require mechanical ventilator? What were the vital signs? Previous antibiotic use, were they immunocompromised because of chemotherapy, as well as the lab investigations, for example, inflammatory markers, the white blood cell count. And we also ventured into unstructured text. So we also pulled out clinical notes because that housed a lot of important information, particularly related to the patient's presentation. So we pulled in progress notes by the doctors. And of course, now that we're dealing with lower respiratory tract infection, radiology report, it's also very key. So for this part of the project, we are not looking at the image directly, but what we have done is extracted the radiologist report of interest, and then we performed natural language processing to essentially identify whether that report suggests compatibility with a bacterial pneumonia or otherwise. So we applied some taxonomy and then eventually classified them into 4 different groups on likelihood before putting them into the final model. So other than radiological compatibility, we were also interested in clinical symptoms, both infectious related and non-infectious related, as well as some other history, like if they were coming from a nursing home or from a community hospital, that might potentially influence the model. So we actually built a few models using different algorithms. The gradient boosting algorithm proved the best, because we had a lot of missing values. So these missing values really came about due to variability in clinical practice, especially in the area of laboratory tests. So in my hospital, we have tests like procalcitonin and C-reactive protein, and not all physicians would always do these as standard tests. So when we attempted to build a model using algorithms that required complete data, they didn't perform so well. And so we felt that we had to go with something that could handle these missing values, because there is actually an inherent value to the way the data is also missing in that sense. So with the XG boost, which is a boosting gradient algorithm, we were able to build a model that was at least an 80% accuracy and 83% sensitive, as well as an 83% negative predictive value. And we wanted to dig deeper to try to figure out how did the model decide what it decided. So what we did was we kind of plotted this Cheah plot. Basically, for those of us who are not so familiar, this is the key features that the model actually used in its calculation, in that order of importance. And so we can see that for the model, the chest scan result is actually the most important determinant. In fact, it accounted for up to 70% of the prediction, and then followed by the procalcitonin, C-reactive protein, cough, and so on and so forth. And the colors just show whether it is present or perhaps a high value for the red ones, and the blue ones reflect if the result is either a low value or absent. So for example, cough, if it's present, falls on the right, and if its cough is absent, falls on the left. And what the two directions reflect is the likelihood or the influence in causing the model to think whether it is a bacterial pneumonia or otherwise. So presence of cough will cause the model to think more likely a bacterial pneumonia, whereas its absence suggests a likelihood of a non-bacterial pneumonia. And so when we look through the list of features as well as the direction, it turned out that it was quite congruent to how a clinician would have made the decision at the bedside. So we wanted to investigate further in what areas that the model might not have performed so well. So in the result, in the output of the model, it also provides another feature called confidence scores. And we noticed that from the box and whisker plot on the left, you'd see that confidence scores for those with the correct predictions tended to be much higher than those with the incorrect predictions. So we're seeing confidence scores at about 80s for those that are correct, but those that were incorrect tended to be around the low 70s. But whether is it falsely positive or falsely negative, we realized that there wasn't really any significant difference. What we thought was quite interesting was when we looked at cases where the model predicted falsely negative, we realized that when we looked at specifically the radiological report, about almost 2/3 of them had a report that did not suggest a bacterial pneumonia. So this might have led the model to think that there is no infection. A few reasons could explain this. I think one of it is that there is often a lag of radiological changes in a patient who is acutely presenting with a pneumonia. And secondly, we have a lot of frail patients as well as patients with very complex lung issues, which make the radiological read very difficult due to the quality of the film. So this was something that we had to keep in mind as we moved on to the next phase of our study. So with the results that we had earlier, we felt that the prototype of this model was kind of good enough for us to move on to a prospective study. So for this prospective study, we did it as an observational comparison, and we wanted to investigate specifically its role and value in the antimicrobial stewardship unit. So what we did was we looked at the daily caseload of our stewardship team. And for our stewardship team, we do our audits based on specific types of antibiotic that it audits for. So we took the daily caseload and we actually fed the data through the model to get what the AI model would indicate the case to be. And then we would compare that with the working diagnosis of the primary team as documented in their clinical progress notes, as well as what the indication documented by the stewardship team after their review of the case. And at day 4, we actually did a ground truth labeling for these cases. So this is prospectively evaluated, but with the hindsight at day 4 after culture results, as well as looking at how the patient has progressed over the last couple of days. And labeling was done together with infectious disease physician who will do a clinical review and then decide if the patient did or did not have a bacterial pneumonia requiring antibiotic use. So over that course of time, we were able to enroll about 1,200 cases. And the median age was about 71 years, which kind of does reflect the kind of adult population that we have in our hospital. We see a fairly equal distribution in the types of infection that we're talking about with regards to the setting. And I thought what might be interesting is to direct attention to the bar chart on the right. So for almost 40% of antibiotics were actually started for what the team thought was an acute bacterial lower respiratory tract infection. But when we actually did the ground truth labeling, we found that only 28% of them were true bacterial pneumonia that did benefit from the use of the antibiotics. And so this kind of corroborates with our finding that there is really a situation of overprescribing and overdiagnosis of bacterial pneumonia. And there is about a 15% difference in the actual incidence. We did an analysis comparing the performance of the 3 strategies, be it working diagnosis of the primary team versus what ASU or the stewardship team would review as, and then what was provided by the AI model. So we looked through a list of performance matrix, accuracy, PP, positive predictive value, negative predictive value, sensitivity, as well as specificity. So all in all, we find that the AI model was still performing consistently with what we saw at the prototype stage, maintaining an accuracy still above the 80% mark. The positive predictive value is also good, but I think what we were most interested in is the high specificity, which kind of served the purpose that we were looking for, that is to identify cases that might be able to have the antibiotics stopped. So if we to look at actual numbers in the confusion matrix between the 3 arms, we found that if we had used the model and allowed it to supplement the prescriber's clinical decision-making, like an augmented intelligence, potentially had the prescriber accepted the AI model's result, we could have saved about 100 antibiotic courses. And if we were to compare that with the stewardship team, we saw that there was still an advantage for the incorporation of the AI model into regular stewardship work, because it did also identify 71 further antibiotic courses that could have been stopped earlier. And then we decided to go deeper, and we wanted to look specifically when the working diagnosis is for a lower respiratory tract infection. And we wanted to zoom into also when the radiologist report is available. So the thinking behind this sub-analysis is because there is also, again, a lag between the image being available and when the radiologist can put up the report. So there are some cases where we found that a chest scan report is not yet available because the radiologist, there was a time interval between the image and the radiologist report, and we didn't have access to the report at the time of the model inference. So we wanted to look at the model performance when we had all the data, especially the chest scan, because it was the most important determinant in the model. And we saw that that really changed the way the model performed, and we saw a significant improvement in the model performance. And you can see that there is a margin of increase in accuracy as well as the positive predictive value compared to the other two arms of the prescriber and the stewardship team. So with that, so these are the specifics according to the 4 subgroups of true and false positives as well as negatives. So for the discussion, I think our results show that there is very much an untapped potential to leverage on AI to help us identify appropriate versus inappropriate indication for antibiotics. So potentially we could use the positive predictive value of the AI to identify cases that have appropriate indication, and that might spare the stewardship team for having to go down to do a manual case review for the patient. And so you can save the manpower efforts and redirect them to other stewardship interventions. At the same time, it can also be used to flag cases that might be inappropriate and would warrant a priority review for these cases, and then to flag them for a consideration for intervention, especially to discontinue antibiotics and really have a difference in terms of the duration of therapy and the exposure. And potentially we found that if we are able to stop antibiotics earlier, patients do get discharged earlier as well. And that does open up more bed space for other patients who are waiting to come in. So we find that there is a role for this as also as a clinical decision support system, because the current ones that we have in place are really targeting antibiotic choice by recommending antibiotic guidelines, recommended regimens, but we don't actually review for whether there is an appropriate antibiotic indication. So very often we assume that the diagnosis is correct, and we then just have the CDSS recommend what would be the more appropriate choice and dose. But that doesn't really address the high amount of antibiotic that is being used in terms of number of patients that are on an antibiotic, course of antibiotic. So we felt that we need something to be added to this CDSS system, and potentially this AI can come somewhere upstream to first evaluate if the antibiotic indication is appropriate before recommending the choice, because it could well be that the patient do not have a pneumonia but might have a different infection like an intra-abdominal or urinary tract infection, for which then the antibiotic regimen that would have been appropriate would be quite different. And of course, so far, the studies that we have been doing are largely retrospective or observational. So our next step is to actually plan for a prospective interventional study across a couple of sites to really investigate whether with the use of AI, with the model being made, the results being made available to clinicians, whether that would potentially change the decision, and what is that impact on the patient in terms of the antibiotic use. But we're also concerned about the impact on the patient safety, and just wanted to be sure that, with the AI model introduced, it did not increase instances of clinical deterioration or mortality. So I think that's what I have. Thank you.
Thanks, Sarah. That's really, really interesting. Amazing work. I'll put it out to anyone else if they have any. I mean, I have a question, of course, but I'll give everyone else a chance. There is a question for Bethany, but we'll save that to the end as well. But I guess while everyone else is thinking about what they would like to ask, you mentioned, the future prospective interventional study. Prior to that, have you done any work about clinician acceptability of the model, I guess, before you go into the prospective interventional study? Like, would they be accepting of that level of specificity and sensitivity? And yeah, is that enough for them to want to believe the model as opposed to their own clinical thinking?
Yeah, you're very right. So we have conducted a recent qualitative study, so that's still undergoing some analysis just to gather what the physicians' perceptions and attitudes are towards potential introduction of AI into their clinical work. I think for most of them, they don't really have that magic number of, oh, it must be at least this number before I'm willing. I think a lot of it is on the ground experience. I think generally 80% is what we would take as the minimum bar. But what we're hearing from the study participants, which really are clinicians, are that they want to see for themselves that the AI is useful for that patient and it does corroborate for cases that they think that the machine is trustworthy and they can follow the recommendations by the AI model. So in terms of getting that behavior of mindset change or habit change, as well as the willingness to accept, that is something that we hope to also do alongside the upcoming interventional study. So we will be interacting and engaging with clinicians as they interacted really on the ground to gather some sort of sentiments as well as barriers that they feel are hindering them from using the model to guide their prescription.
Excellent. Yeah, like you said, it doesn't seem like there's a magic number that everyone will just agree to, but looks like we're just going to have you back at another journal club to present all your qualitative findings then, because that'll be very, very interesting. Was anyone else have any other questions? No, nothing there yet. Just because we've got 6 minutes left, I might then get Bethany, do you want to respond to Susanna's question? So the question is wondering about the underlying workplace culture of the different hospitals. Do you have an impression on this, or did you specifically ask or investigate around the culture of the workplace?
Yeah. So the study actually took a human factors approach with our methods. So as I mentioned in that presentation with the SEEPS framework, we looked at people and their relationships, the tools they use, the organization as a whole in our interviews. And there was a different culture for sure. So like the AMS team at Hospital A, the whole infectious disease department, like all the consultants were involved in the AMS program, whereas at Hospital B, only 3 of the 9 infectious disease consultants ran AMS. And then at Hospital B, there was this general lack of awareness of AMS. They said there was a historical lack of executive support, which was sort of changing now, but then that also impacted like the support they had from other heads of departments. And I think those multidisciplinary meetings also played a role. Like Hospital A had a lot more meetings with all the surgical departments every week. And that, of course, built a lot of rapport between the AMS team and the surgical departments. So that changes the culture as well. So yeah, I think there were quite big differences. And it's interesting because both hospitals had very similar systems, and they are actually quite similar hospitals in the same local health district. So to have such big differences in AMS is quite interesting.
Yeah, thank you. And Susanna's then followed up with, do you think the culture or the tool is the place to focus the change then?
Definitely the culture, yeah. I think the tool is just one element, which but if it's not going to be used, like it doesn't matter how perfect the tool is, right?
Yeah. Excellent. And I guess that sort of question then sort of aligns for you, Sarah, as well, in the way that, but currently the AI models are only being implemented at one hospital so far. Is that correct? And I mean, I guess we're not familiar with the Singaporean hospitals, but do they all use different EMR data systems, or how easily would it be to test that in another service?
Yeah, so for Singapore, we have hospitals grouped into clusters. And so in each cluster, there are actually a couple of hospitals that share the same EMR system and the whole IT architecture and things like that. So actually for our cluster, we have about 5 acute hospitals, and there are plans to try the AI model in one of this other external site to kind of validate and also to see how the clinicians respond to a tool like this. It's just easier to move still within the cluster because we share similarities in terms of the data. But we do have plans to look to expand it to other clusters that would need a bit of redevelopment work to incorporate the way that data is being structured and how their clinicians write their clinical progress notes and things like that. But there is intention and there is interest to move this beyond.
Excellent, very exciting. If there doesn't seem to be any other questions, we might just wrap it up for the day. So again, thank you so much, Bethany and Sarah, for presenting your very exciting research. It sounds like there's a lot that we can learn from both of you, and it's going to be work that's going to be applicable across, not just the hospital setting and, not just pneumonia. So, yeah, we look forward to keeping in touch and sharing all your work. And yeah, we'd love to have you back again when you have even more research to present. So thank you. Just a reminder to everyone that next month our journal club topic has just been postponed to November. It'll be a focus on implementation science, including audit and feedback, which I think is quite of general interest to antimicrobial stewardship clinicians across, all sectors from a One Health perspective, and does have that digital health element as well. Professor Denise O'Connor, who is an implementation science expert, and Professor Jill Francis, also an implementation science expert, will be co-presenting that session. We will also be running it at a slightly different time, but just watch this space. We'll disseminate all that information in our usual newsletter and on Twitter and all that sort of stuff. So watch that space. And we also have some exciting stuff for Antibiotic Awareness Week, which we'll be, sharing through our usual channels as well. So thanks so much, everyone. Have a lovely Wednesday, and we'll be in touch. Bye.